It's my great pleasure now to introduce on behalf of the Planning Committee the individual who will in turn welcome and introduce our keynote speaker, and that is Dr. Philip A. Pizzo. Phil?
Well, thank you so much, Harvey. I am very pleased that Stanford is still here. I want to begin by thanking you, Harvey, for your extraordinary vision and leadership and your wisdom in helping us to shape this dialogue that we're going to have over the course of today. And of course, I'm honored to be here with you representing the exceptional planning committee that we had that worked so diligently to bring this program to fruition. And I, too, want to thank Lauren Shuren, who convened a number of planning meetings and groups to be sure that we at least started with a fixed agenda that made sense. So here we are today, just a couple of weeks away from the election, all pondering what's going to happen to healthcare in the years ahead. I think it is safe to say that there is an enormous amount of hyperbole and not a lot of substance in many of the discussions are taking place, and that's why we at the Institute of Medicine so much want to help shape the future by pondering these very important issues of what we can do to transform healthcare professional education, and with that, create the workforce of the future. Now, today we're going to hear, after a keynote presentation, from 4 panels, each of which will help enhance this dialogue. The first will be about health and healthcare in 2020. We actually pondered whether it should be 2020 or 2030 or beyond, but decided to affix on 2020. That will be a point in time at which some of the current discussion and debate about personal risk, genomics, will be clearer or maybe less clear in terms of how it delineates our risk for disease and how that will help to shape how we can address health versus health care. It will be a point in time at which we'll be able to look at some of the important innovations that have taken place in communication, telemedicine, new devices, where healthcare will be delivered, whether it will be at home, in the hospital, in community, nationally and internationally. It will help to shape the discussion about who we'll be looking at in terms of the recipients of healthcare, increasingly the elderly, largely in urban settings, and by many other professionals other than physicians. Indeed, that is an underpinning of much of our dialogue today. How the incentives will be configured to help payment systems that will lead to healthcare in the future remains to be seen, and how we'll strike the balance between social justice and technical expertise will become important issues for us to grapple with. We'll have an opportunity after lunch to hear from some of those who will be entering the healthcare workforce around this time of 2020, and that will shape the next agenda, which will deal with issues about the changing healthcare environment. What will be the scope of practice? Who will carry it out? What will happen between physicians, nurses, pharmacists, dentists, preventative health, and other specialists? How will they shape the future going forward? These are some of the important issues as we begin to think about team-based and organized care in very different structures and functions. And then finally, we'll talk about transforming the healthcare professional education. We don't want to lose sight of the fact that the underpinning of what we are in medicine is rooted in science and its connections to engineering. And we want to be sure that the next generation is continuing to learn and benefit from these extraordinary skills and insights. But we also need to look at how they will better balance the ability to work in teams, to work with better humanism and professionalism, and how they will, at the end also, learn both from each other and in distant ways through online learning and technologies that are shaping the way we think today. So that's the agenda for today's presentations. Leading it off is going to be a keynote presentation, and I'm honored to introduce Dr. Julio Frenk, who's going to be our keynote speaker. He hardly needs an introduction. He's the Dean of the Faculty of the Sciences at the Harvard School of Public Health. He's the Andropoulos Professor, member of the Kennedy Institute. He is been the Minister of Health in Mexico, has had many national leadership roles, is the author of books that deal with learning about human bodies for teenagers, really an important contribution in its own right, and is a foreign associate to the Institute of Medicine and a Clinton Global awardee. Please join me in welcoming Dr. Frenk.
Thank you very much, Dr. Piso, and thanks to my dear friend Harvey Feinberg for this great distinction of addressing the IOM annual meeting. I'd like to share with you a process of reflection that has been triggered by our human obsession with observing anniversaries. And as you all know, 2010 was the year of the centennial of the Flexner Report. A report that truly transformed the way we think and act upon health professional education. For the 100th anniversary, a number of important activities were carried out and a number of reports were produced. One of them was a report from a Lancet Commission on the education of health professionals for the 21st century. This has been an initiative of Richard Horton, who I understand is a new member of the Institute of Medicine, in bringing the enormous prestige of the Lancet to bear on some of the key topics of our times. And clearly the future of the way we educate the health professionals is one of those topics. So in the course of the year 2010, to mark the centennial, we produced this report as part of a commission. This is the cover of that report in the Lancet, and then there's a book version to facilitate reading. And as I say, this came in the wake of the 100th anniversary of the Flexner Report. But something happened in the transition from the 19th to the 20th century, that the way we educate health professionals became a matter of enormous interest. So a few years after the Flexner Report, in 1915, came the Welsh-Rose Report that did exactly the same thing for the education of public health professionals. And then a few years later, the Goldmark Report, which did the same thing for nursing education, and then a little bit later, the Gies Report, which did exactly the same kind of reflection for the dental profession. So something happened in that period of time, and that's exactly what this commission tried to ascertain. The commission had 20 members. Two very prominent ones were Harvey Feinberg and Patrick Kelly, and actually the IOM played a central role in the planning of this effort. There was also a number of additional groups, most notably a group of youth commissioners, both recent graduates and students in the health professionals. And this effort was supported by the Bill and Melinda Gates Foundation. Tachi Yamada, in particular, as president of Global Health at that point, was an enormous positive force in creating this commission. The Rockefeller Foundation, which of course was very much behind a lot of what happened 100 years ago, and the China Medical Board, and the president of the board, Lincoln Chen, was the co-chair of this commission, and of course I already mentioned the Lancet. The report title contains the message of those deliberations and the basic ideas I'd like to briefly share with you. The title is Health Professionals for a New Century, and then underscored there are the three keywords: transforming, so this is about transformative education, to strengthen health systems, a systems approach to the topic in an interdependent world. The whole notion of interdependence as offering both new challenges but also unprecedented opportunities. Now, what was new about this effort? First of all, it truly had a global outlook. And by global, I do not mean, as we very often do, foreign. Global is not the opposite of domestic. The last time I looked at the world map, the United States was very much part of that, of the globe. So by global, we mean truly encompassing the entire world. And we believe that some of the findings and some of the recommendations are applicable both for high-income and for low- and middle-income countries. It focused on all health professions, There were several other projects, other reports, most of them focusing on single professions, nursing and medicine most notably. This tried to address all of the professions. And although for matters of time and budget, we focused on the empirical side, on the data side, on medicine, nursing, and public health, we believe, again, that some of the ideas are applicable to the whole array of health professions. It took a long-term perspective based on post-secondary education, a lot of reports coming out about, mostly for developing countries, from community health workers. This really looked at post-secondary education, typically degree-granting institutions, typically universities and similar institutions. It provided an integrative framework and then a series of specific recommendations. So I'd like to share with you in these brief remarks some of the thinking about it, and this will be a very brief summary. If anyone who's interested can access the original report, which has much more detail. So five major topics. What's the context? Why this report at this particular time? What was the framework, some of the major findings, some of the recommendations? And then a lot has happened in the year and a half, almost 2 years, since this report was launched at the end of 2010. So let me start with the context. The 100 years since the Flexner report are not any 100 years. These are the 100 years of the most profound, tense, and intense transformation in health conditions in the history of humankind. We started the 20th century pretty much with the same life expectancy since the beginning of humankind. This, of course, is a simplification. What happened was that life expectancy was low, and then you had huge mortality peaks. You know, the Black Plague came around, and you had a huge peak. The Europeans came into contact with the New World, so-called New World, and another peak. But basically, we start the 20th century with about 30 years of life expectancy as a global average. Something happened in the 20th century that by 1985, that level had more than doubled to 65 years. So in this brief period of time, humankind as a whole achieved a larger gain in life expectancy than in all the previously accumulated history of humankind. That's why I say these are not just any 100 years. Now, why? What did this happen? This has been a matter that has concerned many, many people for a long time. There's two basic explanations. One was that this was just a reflection of growing wealth, because, you know, wealthier societies can educate people better, have better housing, better nutrition, and that is partly true. But this classical graph from the work of Sam Preston shows that indeed, although each of these dots, by the way, is a country, even though indeed as income grows, life expectancy grows, the most interesting part of this graph is that for every decade of the 20th century, there was an upward shift in this curve, so that for any given level of income per capita, life expectancy was higher with each successive decade of the 20th century. And that difference is the contribution of knowledge, not of income per capita. And you see it very clearly when you compare the country of Chile, which by just a fortunate coincidence had exactly in 1990 the same income per capita, obviously in constant dollars, than the United States had in 1900. So with exactly the same income per capita, Chilean women in 1990 had a life expectancy of 79 years compared to 48 for American women in 1900. This difference of about 30 years is a contribution of knowledge. How does knowledge improve health? Well, a very clear mechanism is knowledge gets translated into technologies, better drugs and vaccines. This is the best known way. But knowledge is also translated into evidence that shapes human behavior in key domains of everyday life: personal hygiene, sexual behavior, nutrition, physical activity, the way we bring up children, etc. And then finally, evidence gets knowledge translated into evidence, hopefully informs policy, although Harvey's reflections is making me having second thoughts about that effect. The reason I'm telling you all of this is because, you know, a commission report by health professionals saying to other health professionals that there's nothing more important in the world than how we educate other health professionals really wouldn't be very interesting, were it not for the fact that health professionals are actually the key actors in this process whereby knowledge has driven this health revolution of the 20th century, which is an ongoing health revolution in the 21st century. Because health professionals are at every step of this process. They are the creators of knowledge in their role as researchers. They develop the technologies, and very importantly, in their practice, they apply those technologies to patient care. They provide a lot of the translation and educate the public so that evidence can guide behavior, healthier behaviors, and health professionals are more often than not in positions either themselves as policymakers or in positions of influencing policy. So if knowledge has been the driver of health improvement and health professionals are themselves the key creators and brokers and translators of knowledge, then how we educate health professionals becomes truly a very, very important matter. This also happens at a time of unprecedented challenges on health systems, and I'm not going to dwell on that. Huge epidemiologic and demographic transformations around the world, a rapid aging of the population, much faster by the world in developing countries than what currently developed countries experience, leading to a very complex change in the dominant patterns of health and disease around the world, an era of unprecedented technological innovation, huge population demands as access to healthcare is conceived increasingly as a human right and not a privilege or a merchandise, and then finally a period of unprecedented professional differentiation, again, all of this happening within the last 100 years. So in this context, we actually thought that this was a worthwhile undertaking. We developed an integrative framework. I don't have time to go into the details. I'll just show 2 slides, but again, you can look this up in the report. The first, I said we adopted a systems approach, a systems perspective, trying to link what happens with the health system and the education system. The foundation of both systems is a population that has health needs, which get translated into demands, and when there is a provision of health services to meet that demand, that creates a demand for the health workforce. The same population has educational needs, which are articulated into demands, and again, when there's a provision of an educational service, that creates a supply of the health workforce, and these 2 sides meet in the labor market for health professions. Of course, academic healthcare systems have a foot in both of those systems. If we zoom in to the education system, our report adopted a comprehensive approach, focusing for sure on instructional design, which has been the most common focus, looking at actually the content, the curriculum, the criteria for admission, the graduation pathways, or the pathways upon graduation. We decided to also look not just at the instructional, but also at institutional design. And that was inspired by the Flexner report. If you read Flexner, it's not just an attempt to answer the question of what and how we teach, which is basically the matter of instructional design. It's also a question of where do we teach, and that's the institutional design. A very fundamental statement that medical education ought to happen in university-affiliated schools, not proprietary independent schools, with a certain type of departmental organization, with a teaching hospital affiliated, et cetera, et cetera. So we did the same thing. We adopted a series of analyses, but contrary to what happened with Flexner, which was mostly focused at the organizational level, the level of each individual school, we also tried to look at the entire education system. And then something that is new compared to 100 years ago is that we can really think of a global level of institution building. And I will talk a little bit about that. What are the kind of global consortium networks that in the 21st century we can envision to move health professional education forward? In the instructional design, we adopted a life course view with the 4 C's, the criteria for admission, the competencies, the channels, meaning the methods and technologies for instruction, and then the career pathways. And then with 2 proposed outcomes, interdependence when it comes to institutional design and transformative learning in the instructional design. And I'll explain those in a little while. What are some of the main findings? Again, just a very brief overview. First of all, we do find a number of systemic failures, huge mismatch of competencies to actual needs, weak teamwork, still major elements of gender stratification, even though women are the vast majority of the health workforce and increasingly of the professional health workforce, still underrepresented in positions of leadership, still hospital dominance over primary care as settings for education, huge labor market imbalances around the world, literally countries where you have communities without doctors in the countryside and doctors without jobs in the cities, This is not a rare occurrence, so huge imbalances among the various specialties, and then weak leadership for health system performance. More specifically, we found, if you take a global look, enormous variation, as you might expect, in the availability of resources. This is an indicator of density of medical schools, the number of medical schools per 10 million population, and you see huge variation across the globe. Same thing for schools of public health. This is my favorite graph, and this was actually the cover of The Lancet, where the report appeared in full. A huge mismatch between burden of disease, where you see a hypertrophic Africa, and the supply of the workforce, which you see almost a mirror image, I mean almost the opposite image in terms of what human resources are available and the size of the burden of disease. There's a large number of countries without medical schools, still 0 medical schools, about 31 in 2008, which is the year of our data. A large number with only 1 school, and of course, not surprisingly, these are concentrated in sub-Saharan Africa and South Asia. And at the other end, 4 countries of the world concentrate about 3/4 of all the medical schools in the world: China, India, as you might expect, Brazil, and the United States. Those 4 countries concentrate the vast majority of medical schools. I don't want you to read this, but just to show that we actually carried out a almost heroic effort, because a lot of this data is not readily available, and all of these indicators are there: the number of graduates, the size of the workforce. No report is good, and the IOM is, of course, an expert in this, if it doesn't have a surprising finding. And I have to tell you that the finding that truly surprised me was that we carried out what I believe is the first ever measurement of how much the world is investing in health professional education. And we did this work along with the World Bank, the group led by Alex Precker, and we found that the world as a whole spends about $100 billion in health professional education. It sounds like a lot of money. As it turns out, this is less than 2% of total health expenditures in the world, which is about 10% of the world economy. And back in those years, that was $5.5 trillion. It's now close to $7 trillion, what the world spends. Even the United States, of course, with a much larger denominator, that proportion is even smaller. And I had spent about 25 years of my life trying to understand why is it that in every country in the world, people are dissatisfied with the performance of their health systems. Everyone feels that we're falling short of where we ought to be, that there's a gap between what we achieve and what we could be achieving in terms of performance. And suddenly it hit me that there's no industry in the world of this size, representing 10% of the world economy, $5.5 trillion back then, that devotes only 2% of its total financial resources to the education of the leaders that are going to make most of the decisions about how the other 98% gets spent. And that was an interesting finding. I do not distrust economists. In fact, I'm married to one, but we actually asked them to do 2 different approaches to estimate this, and I was very relieved to see that both approaches converged, and they do confirm, as you might expect, low levels, but then again, a huge inequality across the world in how much is invested in health professional education. In the United States, this was just for medical and nursing education in 2009, and this is how much it was spent, $5.5 billion. And some comparators, some very good things like the NIH budget, over-the-counter drugs, more than twice as much, and complementary and alternative medicine. We also carried out a comprehensive, systematic literature review of almost everything that's been published on health professional education in the last 100 years. And I just want to highlight one interesting finding, which is that most of what's been written has been about medical education, about 3/4, second, nursing education, and that actually public health education, the education of public health professionals, which is my current responsibility at Harvard, accounts for only about 2% of the literature of the past 100 years. So an interesting finding, and again, all of this is available. Now, what were some of the main recommendations? And again, I'll just give you a quick flavor, and I will emphasize 2 of them. First of all, this report comes after a huge amount of progress has happened throughout the past century. And it was actually Harvey Feinberg, as a member of the commission, who thought of this idea of 3 generations of reform that we've labeled as the first generation we call science-based reform, around the turn of the 19th to the 20th century, basically with the Flexner and the related reports, where the main instructional innovation was a scientific curriculum and university-based education on the institutional side. Around the 1970s, there was a second generation of reforms, which we call problem-based, with problem-based learning as a major innovation. And then we're now, at the beginning of the 21st century, in a third generation of reforms, which we call systems-based reforms. I use the metaphor of generations to really signify that just like with human generations where you have grandparents and children and grandchildren all alive together, these generations are still very much alive and vibrant and relevant. We still want very much to have a science-based education. Problem-based learning is incredibly important nowadays. So we build on the previous generations of reforms. This was the vision, two main outcomes that I'll explain in a minute for equity in health, both for patient-centered care of individuals, but also for population-based, a population-based approach to health. There are 10 recommendations, 6 on the instructional and 4 on the institutional design question, and then a number of enabling actions. Not surprisingly, enhancing investments is one of those. I am not going to talk about all of those. I'd like to emphasize just a few of them. First, the idea of competency-driven education, the complexities of local responsiveness, but with global connectivity. We do have a globally mobile workforce. About a quarter of physicians practicing in the United States were trained or educated elsewhere. So, how they get educated is a very important matter for healthcare in the U.S. We're very strongly for mobilizing the revolution in communication and information technologies in the service of education, very much in favor of open access to educational resources. We talk of a new professionalism, and then on the institutional side, a number of ideas, mostly this idea of global networks that I will mention in a minute. So just let me emphasize a couple of the recommendations. First, and again, this is not the only report, there's actually a whole movement that's been around. We commissioned a very, very good background paper on competency-based education. But the essence here is that in the traditional model, the curriculum is the point of departure, and the curriculum typically reflects the interests of the faculty and the way they themselves were educated. The curriculum is a very, very powerful force for social reproduction of the professions. And then from the curriculum, we derive some objectives, which are intermediate educational objectives, and that's what we assess. In competency-based education places this on its head. The point of departure is not the curriculum, that's the last step. The point of departure is the health needs of populations and the requirements of health systems. You derive competencies understood as outcomes, not as intermediate objectives, and this is what you assess. And then on the basis of the outcomes, the competencies that you hope to develop, you design a curriculum. A very, very powerful transformation. In many, many professions, we've seen an effort to develop competencies, but very often, it's just a case of linguistic updating. It's really the old objectives, we just relabel them competencies because that's fashionable. This is a different approach. I think this is really thinking hard. What is it that populations express in terms of the needs and health systems in terms of the requirement? And that does not mean that educational institutions should be subservient to the requirements of the health system. A big part, and we talk about this in the report, is that education institutions should be a source of critical reasoning and innovation in the way we organize the financing and delivery of health services. So this is one of the important recommendations. The second is on interprofessional education. Again, most of the reports appearing in the course of the centennial year of 2010 emphasize this. The idea is basically that in the dominant model, you get students that have a common pre-secondary education experience, and then we silo them when they come to the university level, the post-secondary level, into different schools. And when they hit the reality of their work life as professionals, they find that teamwork is actually what's required in this era of complexity, and yet we're surprised that nothing in their education actually prepared them for teamwork, and that these are competencies were not developed. In interprofessional education, those competencies become explicit and become a part of the educational experience. This has led to a whole movement. The Macy Foundation, and I see George Thibault here, has been, along with all the associations of the health professions, been actually following up on very practical steps towards interprofessional education. What our report added was the notion of transprofessional education, because in a lot of countries in the world, in addition to working with other professionals, you have the challenge of working with the non-professional side of the health workforce, notably community health workers. And that requires other competencies, like, for example, cultural competencies. And by the way, this may be a growing reality in rich countries as an example of what's being called frugal innovation and lessons from less developed, more resource-constrained settings to richer settings, as the richer settings themselves struggle with cost containment. Finally, I mentioned some of the outcomes. One of them is the idea of interdependence and the possibility of mobilizing the revolution in information and communication technologies to actually build networks of institutions all over the world. If we think that the 193 sovereign member states of the world, each of them will be able to educate its full complement of doctors, nurses, public health professionals, and all the other health professionals, that's just not going to happen. And I think the enormous prospect of online education and other forms of building global networks and consortia will be enormously powerful in creating or meeting the needs of health systems around the world. The other important recommendation or desired outcome is what we call transformative learning. You can think of three levels of learning, which we call informative, formative, and transformative learning. In informative learning, as the name implies, the basic idea is to convey information and concrete skills. The outcome is an expert, but that's obviously not enough. We have to go to the next step, which is formative learning, where in addition to information and skills, we try to develop competencies in values. We socialize future professionals into a set of values, an ethic of service, and that's what transforms an expert into a professional. We suggest that that's yet not enough, that we need to go to the third level of transformative learning. And here what you develop are leadership attributes so that health professionals are not only experts but also change agents. That doesn't mean they're going to be picketing in front of the Capitol demanding health reform or anything like that. It means that in today's complex health systems, no health professional can be simply an expert, although we very much want them to be experts, but need to be aware of the larger social context in which they practice their profession and then become proactive members of an effort to improve the overall design of the delivery systems in which they work. Let me end with a brief update of what's happened since this report was launched in the end of November of 2010. A huge amount of interest. The commission, by the way, dissolved after it produced its report. It was not meant to be a permanent body. But subsequently, and this has really been from the ground up, there's been 20 worldwide launches. The report has been translated into 6 languages, Vietnamese, Chinese, French, German, Spanish, and Portuguese. There's been a number of very interesting national initiatives in all of these countries. In the US, I just highlight here the fact that being now the dean of a school of public health and having seen that only 2% of the literature deals with the school, I thought it was an act of personal congress to actually try to apply some of these recommendations to my own school. So we're embarked in a very major redesign based on the recommendations of the report. There's a couple of very interesting regional networks, the MEPI and NEPI, the Medical Education Partnership Initiative, and I see Roger Glass here. This has been very much, the Fogarty Center has been at the forefront, building on the PEPFAR experience in Africa, a very important, and the Nursing Education Partnership Initiative. This is a very important set of initiatives, and then a network of 5 Asian countries, including China, India, Bangladesh, Thailand, and Vietnam, that is also doing very, very interesting innovations. I'd like to focus, and President Feinberg already alluded to that in his report, to the IOM Global Forum on Innovation in Health Professionals, education with the series of innovative consortia, which I think, and he already dealt with that. Afaf Melis and Jordan Cohen are the co-chairs who were members, who were commissioners, are the co-chairs of this global forum with the very able support of Patrick Kelly and the IOM staff, and a very, very large participation of a number of organizations. Just one slide, and I will be done, of what we're doing at Harvard School of Public Health. We've embarked in a large-scale transformation of our education based on 5 principles, which I think have broad applicability. First, I already spoke of competency-based, but we add the idea of a T-shaped individual. I take this from the Dean of the School of Engineering at Harvard, Sherry Murray, who speaks of T-shaped individuals, individuals who have a great depth of knowledge, but also develop the horizontal ability to relate to other fields for effective teamwork. A multi-dimensional approach to interprofessional education. When it comes to public health, we have a challenge because most of interprofessional education has been among the clinical professions. And how do we bring a population perspective, and how do we bring the non-health professions that have such an impact in health, like lawyers, like business people, communicators, into the work, into an interprofessional education? The notions of modularity and flexibility, the ideas that you can use, that you can view higher education as a tube with one opening, that's admissions on one end, another opening, that's graduation, and then something hopefully good happens while you're inside the tube. I think that's an outmoded idea. We need to have much more open systems with multiple points of entry, truly in a lifelong effort at leadership development. And then the technological revolution to enrich pedagogical innovation. Today, just by chance, is a very, very important day. Today, as we speak, the first massive online open course of MOOC by edX, a new venture of Harvard, MIT, and the University of California in Berkeley, is launching its first courses. There are only 2 courses. One of them is a public health course in epidemiology and biostatistics. As of last Friday, there were 40,000 people enrolled in that course, which I think makes it the largest course in the history of public health education. But the most interesting thing is, as you might expect, the first contingent is from the United States. The second largest is from India. About 8,000 people from India are starting to take that course today. Today is the first day. It will be the matter of a lot of evaluation, and we will see how well that works. And then finally, a fundamental principle. We are used in the research enterprise to certain values of excellence, collaboration, peer review, and formal explicit assessment. When we do to our SERM faculty, who are totally used to this when they submit a paper, if we say, you know, we're going to peer review your instructional prowess, we get a very, very strong reaction against. And I think we should adopt exactly the same principles of openness and peer assessment to education as we do to research. Let me finish where I started. You know, we can think of a circle of knowledge that involves the production of new knowledge through research, the reproduction through education, because good education not just transmits knowledge, it recreates it in the minds of the next generation. Its translation, both into technologies and into evidence that empower people and enlighten policymakers. And then the implementation. And when we implement, when we act, we close the circle because we study the effects of human action, and that starts the circle all over again. Health professionals are the key factor in this entire circle. As researchers producing knowledge, as educators reproducing it, as practitioners taking that knowledge, translating, educating the public, as policymakers formulating policy, and then in their daily practice. And this is exactly why this topic is so fundamental. So let me close with the exact phrase we used to end our report. And it's a quote from a beautiful book that was published in the same centennial year, 2010, by Louis Menand, a professor at the Harvard Department of English, who wrote the following: "The pursuit, production, dissemination, application, and preservation of knowledge are the central activities of a civilization. Knowledge is social memory, a connection to the past, and it is social hope, an investment in the future. The ability to create knowledge and put it to use is the adaptive characteristic of humans. It is how we reproduce ourselves as social beings and how we change, how we keep our feet on the ground and our heads in the clouds." And this is exactly the challenge, how grounded in a profound knowledge of reality we can keep our heads in the cloud, in the clouds, envision a better future, and use health professional education to drive the transformations for the 21st century. Thank you very much for your kind attention.
Well, thank you so much, Julio, for a really wide-ranging and stimulating opening presentation. We have an opportunity now. There are microphones positioned in the aisles for questions or comments that any of you would like to raise for Dr. Frenk. So let me begin here, and we'll work our way around. Could you, for the purpose of our web-based program, could you identify yourself as you begin to speak? Thank you.
DeAngelis from Johns Hopkins. I stand here and I am just absolutely impressed, first of all, but also a little bit, I stand in awe because 39 years ago, I wrote the first textbook for nurses and physicians working together to provide primary care for pediatricians, pediatrics and children. I'm a pediatrician. But I was then, at that point, had my training in nursing and in medicine and in public health. And it seemed to me that it was a natural thing, that there were certain, the puberty rituals involved, and that's what I call them, for the education to become those three entities, are so different, and yet so much married. I could not imagine why we couldn't do exactly what you're proposing. And then the nurse practitioner movement sort of got us started. But in 1992, with Dr. Mike Johns, who was dean of the medical school at that point, we got a grant to change the curriculum. And there was a number of things we planned to do and did accomplish. One of them was to at least have one course where we would be educating physicians and nurses together. And then a proposal for a clinical setting, and what we were trying to do, what I wanted to do, was to let every medical student act as a nurse for at least a month. It was amazing. It was the nurses who objected to it. They were worried about the patients. What else can I say?
Comment on that?
Well, I mean, congratulations, and you were obviously ahead of your time. I have to say that interprofessional education is a very, very strong movement. As I say, I mean, we actually built on, there were a series of reports on the centennial year. I think this is, I mean, we need to get to the specifics. And to me, you know, as dean of a school of public health, and you did mention that, most of the conversation has been about interprofessionalism in the clinical professions, which is a very important step. The recent report that Harvey also mentioned of primary care and public health, I see primary care potentially as a place where we can actually intertwine also the population perspective. And some provisions of the Affordable Care Act, like the creation of accountable care organizations that require the marrying of you know, excellent care of individuals with responsibility for a whole population, I think we'll finally realize the vision you had so many years ago.
Please.
Henry Foster, Meharry Medical College. Thank you very kindly, Dr. Frenk, for the presentation. My question will be succinct. The very top, you talked a lot about life expectancy. So in my experience, and I would like to know your opinion about the effect of infant mortality as one of the quickest ways to increase life expectancy as you lower infant mortality.
Yeah, I mean, for sure, the major part of the rapid rise of life expectancy in the 20th century was due to a selective decline of mortality among young children. I mean, that's the driver. As we move along the epidemiologic transition, then other reductions in mortality at later ages also start weighing. But the main driver by far is the decline in infant mortality, which, by the way, then triggers the decline in fertility, because every society where we've seen a decline in fertility, that's preceded by declines in infant mortality as couples have certainty about the survival of the children, and that then that's the major force driving the aging of the population. And those two together drive the epidemiologic transition and this vast change in the human experience of disease, which until the 20th century was mostly a succession of acute episodes. The big change in the 20th century is that the experience of disease is no longer a succession of acute episodes from which you either recover or die, but becomes a condition of living, a chronic condition, a condition with which you live. And that's exactly the force. But it all starts with the decline in infant mortality, and under 5 mortality, but especially infant mortality.
Thank you very much. Yes, sir.
Thank you. I think we have one more question here before I'll move down to the other microphones. Please.
Hi, my name is Eche Ezanoloe from University of Nevada School of Medicine and the former Robert Wood Johnson Health Policy Fellow. I also happen to chair the Education Committee for an Association of Nigerian Physicians in the U.S. So I'm one of 4,000 physicians that received their training in Nigeria and in the United States, but now practice in the United States. So one of the things we've been trying to find out is how can we give back to that community and be part of that program you're talking about, where we can actually help in educating new people, maybe to replace us that already left the country. We haven't been able to find a solution, and I wanted to know, how do you think we could contribute in doing that? Now that we practice here, we have achieved. I'm an associate professor of pediatrics in the school. I've been going to Nigeria 1 month every year. I've been trying to find how can I actually effectively contribute in training the next generation of physicians.
So it's an excellent question, and I happen to be flying tonight to Nigeria, so I'll have a long flight to think about your question. But no, I really think that, what we are evolving, we already are in a global marketplace. You are an example, I'm another example, of people moving around the world. The enormous amount of interest in global health among medical, nursing, public health, and other health professional students is just, at least in my lifetime, I've never seen that level of interest. So we really are much more of an interdependent world. And I think this opens the opportunity, along with the communication and information technologies, for really developing the kind of global consortium networks that I was talking about. You do have the expatriate communities. A lot of what's going on now in China and India is a return of the diaspora in the health professions, which is fueling a lot of the progress in research and in professional practice as well. So we need to embrace this interdependent world and be aware, and this is a challenge we talk about that I didn't have a time to summarize, but how do we assure global common standards so that a doctor is a doctor is a doctor, or a nurse is a nurse is a nurse? There's a common set of standards, while at the same time being rooted and responsive to very different local realities. It is totally different to practice in an African village where you may be the one physician for 40,000 population, and you need to have a number of competencies to lead a very diverse team taking care of those 40,000 people, that to practice medicine in the Longwood medical area where I now reside, which reportedly has the highest density of health professionals per square inch in the world. So it is very different, yet we need to recognize both as health professionals. How do we get to that balance of global competence, especially with a globally mobile workforce, but at the same time responsiveness to local circumstances? And our report goes into a lot of depth into that question. I think one of the vehicles is to utilize the force of the information and communication technologies and the enormous interest among students to serve as vehicles for that kind of interdependence.
Thank you, Dr. Frenk. We have time if we have concise statements or questions and concise answers for the 4 questioners who are remaining. So.
Concisely, I'm Kathleen Dracup, Dean Emeritus at UCSF School of Nursing, and I think in academia we are all struggling with how to create opportunities for interprofessional experiences early in the curriculum, not just counting on these clinical opportunities once students are out into the clinical realm. And so, of course, coming from Harvard or with Dean Piso thinking about Stanford, do you see in our lifetime opportunities for schools of nursing at these universities?
You can actually give a very brief answer.
Yeah, Harvey, I have to, the answer is yes. Yes, and I think there's a number of experiences elsewhere that will be very fruitful in a truly global dialogue, and I hope the IOM Forum will be a major driver of that.
And what do you see the barriers?
What do you see?
The barriers to
That's a
schools of
longer
nursing being established at Harvard or Stanford or other
Do you want to comment?
Ivy League universities.
Well, in a word, history.
Right.
But this is a longer discussion, and it's a very important discussion.
Thank you.
Thank you. Yes.
Judy Wasserheit, University of Washington. Julio, thank you. Congratulations again to you and Lincoln and all of the commissioners. This report, as you know, is something that's been of great interest to the whole consortium of universities for global health, and I think the whole field. I think the devil is in the details, so I would love to hear a little bit more of the specifics about how you're approaching this at Harvard, particularly with respect to two things. One is, as you go beyond the clinical interprofessional team teaching, outside of health sciences especially, how are you thinking about that, how are you doing it? And secondly, particularly in the current economic environment that's really hitting universities hard, what are the kinds of business models that you're thinking about as you move toward these models for team teaching both within and beyond health sciences?
We're over the time, so I will only say that we are right now working. We will actually finish our process at Harvard specifically on November the 1st, 2013, in time for our own centennial, which will be celebrated then. You will receive an invitation and all will be revealed then. But the questions you ask are very, very profound, and those are exactly the right questions. Just on the last one, I think actually interprofessional education will become a necessity in the new healthcare environment. And so rather than being a burden in terms of figuring out, we need to figure out how to make it sustainable, but I think it is the right response in the changed healthcare environment here in the United States and actually in most parts of the world.
Let me invite both of the last two questioners and then final comment. Bob, it's yours.
Bob Brook, Rand, UCLA. I thought I'd ask two ridiculous questions that probably the Commission only would address after alcohol. The first is, did the Commission imagine a world, an alternative world, that would eliminate the need for health professionals and reduce the dependence of population health on any health professional? And second of all, did the Commission have any discussions of the relationship of the health of humans and the health of the planet in discussing the future needs a century from now of production of health professionals?
No and no.
Yeah, the answer is no and no. We did, however, we do have a very explicit analysis of how the current boundaries are a product, as Harvey said, of historical forces, and how a more rational redesign would be called for. But I do not think we will have a future where we don't need knowledge-intensive, knowledge workers actually making knowledge the driver for health improvement. In fact, I wouldn't like that future.
Please.
Hi, I'm Carmen Green from the University of Michigan. And one of the things I would say was actually a systematic failure has been our approach from an interprofessional perspective to deal with the increasing disparities and inequities in health. And I would ask how you would address some of these issues in an interprofessional type of transformation of the educational system for the learners.
It's a great question, and actually the report does dwell on that very question to great length. So I would invite you to read, because we do deal with those, both the disparities across the world and within countries, and the need for making the understanding of those disparities part of the explicit competencies that are developed during the educational process, and making educational institutions themselves a force, part of the notion of transformative learning would very much involve the capacity to analyze the larger context in which one practices, and that would certainly have to include the issue of disparities. But the report actually dwells on that matter with quite a high level of detail.
Thank you. Please join me in thanking again Dr. Julio Frenk. At this point, we're going to be able to take a break. I do want to announce that as you leave the auditorium, you will find available for you to pick up the supplement to the President's annual report, which contains a deeper description of impact over the past year of the work of the Institute of Medicine, a more complete overview of the work of each of our boards, a summary of financial information, and a listing of our contributors and supporters. So I commend that to you for your attention. We will also have available the official press release for the election of the new Institute of Medicine members elected this year in 2012. That will become public as of 10 a.m. this morning. You will find also a brochure describing the achievements of the recipients of this year's awards, which I commend to you, some of whom we have recognized and others we will come to recognize a little later in the program. And finally, I want to mention and to thank an anonymous member of the Institute of Medicine who has provided a matching grant to the Institute to match the gifts of all members of the class inducted this year. That's the class of 2011, and a brochure describing that program is also available. We would like to reconvene promptly at 1/4 the hour, so please be here back in your seats at that time, and we'll proceed with our first panel. Thank you all very much.